Mainly, this case discussion is more about bringing out the points, how to basically differentiate the problems arising out of hip and spine, and what is to be done. So this is a 68-year-old female patient who presents with predominantly progressive axial lumbar back pain that she describes as severe, and over the course of the time the pain has gone on increasing. She walks with a stoop posture. She has a bilateral lower limb claudicant pain and radiation to thigh, both anterior and posterior parts, and pain is exacerbated by walking, and there is no specific distance where she gets this claudicant distance. It depends from varied from time to time and time of the day. With the onset of lumbar pain, she also feels her legs becoming heavy, and she also feels pins and needle sensation in both the feet. And she is already on treatment with medications and physiotherapy. I would like to go to Amit. Is this history for you to call it as or go to a diagnosis, or you want to know more?
As we know that degenerative pathologies are fairly common to be present both in the hip, spine, and in the knee also, for that matter. So actually, my talk is on the hip and hip spine syndrome and injection technique. So I just went through the literature also in the last few days, and it's a very complex process. We have to do a good physical examination, good imagings, very thorough imagings, and
No, in terms of history, because we are talking about hip spine syndrome, it need not be just a hip. So this history is itself sufficient, or in terms of history, would like to know more.
I think only history will not be sufficient. We have to go through the further
No,
examination. It could be both.
in history, you will have any direct questions to the patients, like whatever she has described. Is this enough, or you'll put
So
any?
the one thing which I'll ask specifically is the groin pain. If groin
Yep.
pain is then there is a chance that the patient is primarily suffering from the hip pathology, about 7 times more. Uh, Tingling numbness, pointing more towards the spinal pathology, but that can be there in the patient with the hip pathology as well.
Okay.
So no, I would not relying
Okay.
on the history alone.
So, on probing, she also says she experiences groin pain while walking, but even though it is not as disabling as a back pain, but she does experience groin pain, and it is also there when she is getting up from a sitting position. This is just a slide, and it says that, as Amit was saying, the groin pain is a more of an indicator of a hip pain rather than any spinal pathologies, and it is 7 times more likely that patient is going to have a hip pathology. And as Amit again mentioned, there is where usual dictum is, if the pain is going below the knee, it is not due to hip, but then in 47% of the patients it can go or radiate below the knee also. And the another pain which we have to be careful, that is lateral hip pain, which can occur both in spine and due to the hip. In this patient, examination wise, patient had a kyphoscoliotic deformity in the lumbar spine. She had a diffuse tenderness. Straight leg raising test was negative. Neurology was pretty much normal, other than patchy areas of some sensory numbness. And examination wise, Priyank is going to deal with this, how to differentiate. Hip movements were restricted more towards the left than right, and Faber and internal rotation were positive, and there was a groin tenderness mainly on the left side. So that's the X-ray. I'll just go forward, and that's the whole spine X-ray with the values. Dr. Iyer.
Yeah, so I think that if there's symptoms on the left side, one thing is I can't quite see the pelvis, so would want to see that. But just looking at it, the collapse at 3-4 especially is on the right, not the left. I would expect more groin type of symptoms if they are coming from the spine to be on the right. So that part of it is obviously a leading question because we're in the hip spine symposium, but I think that that's something to look out for. Maybe I missed it on the history, but like one of the big differentiating factors is pain getting in and out of seated positions. You know, it's not so much standing and walking, which can be claudicatory or the hip, but I've found that getting in and out of a low seated position, so for example, getting out of the car, going from sitting to standing, those types of symptoms, I think, point me more towards the hip. It's one of the signs on history that I look for. But looking at this, you know, I think it could be either, and you'd want, for sure, I'd want a dedicated AP pelvis.
So in this lateral X-ray, if you see one of the hip is more flexed than the other, does that make you worry, or does that make you investigate more?
I think the history more than just that, because, you know, sometimes when the X-ray tech or when they're standing, they get direction. I don't, you know, again, if it wasn't for the Hip Spine Symposium, I'm not sure I would have picked up just on that.
Okay.
But I think the history certainly would make me get an AP pelvis.
Okay. Priyank, so how do you basically now proceed with this? Like there is Priyank? No. Okay. So there is some history suggestive of groin pain, hip pathology is there. And you would like to, how do you want to differentiate all the symptoms?
So here, I think one very important part is the clinical exam of the patient, because the history is giving us both the clues that there's some problem with the spine and the hip. We have an X-ray which also shows that there's osteoarthritis with degenerative scoliosis. An examination of the patient is going to be very important, and of course you want detailed imaging in terms of the MRI to know, because even the anterior thigh pain could very well be because of a higher lumbar stenosis causing radicular symptoms. So a combination of all of this is
So how do
eventually
you
going to be-
differentiate a pain, anterior thigh pain because of the lumbar spine and because of the hip?
So that's something that I'm going to talk in the coming few slides.
Okay.
Yeah.
So that's the hip X-rays. Dr. Uday?
Yeah,
Yeah.
there
So-
are arthritic changes in the hip joints.
Yep.
We can clearly see. So again, go back with a clinical examination will be the mainstay, and if we go for another investigations in the form of MRI, the MRI screening with pelvis and hip joint will be mandatory.
Okay. Why do you want to do a hip joint MRI? So in this case, do you think the symptoms primarily are because of the hip or the spine? So whatever we have seen.
Yeah, okay.
till now.
Again, it's dilemma is there. That's why we want to rule out everything.
Okay. This we know that now both pathologies are existing after the investigation. This looks like basically the classification is of 4 types. I'm not going to go through that because of paucity of time, but this is like a simple primary hip spine syndrome where we know the predominant symptoms are coming from the spine, and hip also has a pathology, but it's not really bothering her. So conservative injection surgery, I think injection Dr. Uday is already going to cover. Already she has undergone a conservative treatment enough, but then the deformity is progressing. And this is an algorithm when you have both hip and spine problem. It's a little busy slide. The gist of it is basically a majorly groin pain with major OA. Then you have to do a basically fluoroscopically guided injection into the hip and see whether these patients get relief. So injection into the hip joint actually is shown to be 87% basically sensitive and 100% specific to diagnose hip joint pains or pain arising out of the hip. So what comes first? Dr. Iyer is going to talk about it. I'm not just going to go through a lot about it. Mainly, a lot of papers say that always spinal fusion comes first as compared to hip total hip arthroplasty. That's because there is 2.7 times higher risk of having a dislocation of the hip and increased risk of infection, revision surgeries, and prolonged opioid use if we do a THR first as compared to lumbar spinal fusion. But then there are papers on the contrary which say that if you do only THR, the back pain can go away to the tune of 82% of the patients when they only have back pain when they don't have any leg symptoms. So usually as a spine surgery itself is not done for the back pain, but then if you have only back pain and the major hip OA, then the THR is done primarily. In this case, I'll just rush through. In the first stage, we did 3-level OLIF from front, and that's the X-ray after OLIF. You can see this basically the positive societal balance has improved, got a reasonably good lordosis and correction of a coronal imbalance. And second stage, we did fixer up posteriorly and did a L5S1 MIST lift. Thank you.
So, Guru, before you go,
Yeah.
final outcome of the patient, was the patient completely happy? Or
Yes.
pain
So the thing is, this last slide I just actually didn't go through. Patient right now is symptom free, but it has been shown that whenever we do more than 3 level fixations, the hip joint space gradually goes on reducing. Already she has hip arthritis, more on the left, less on the right side. I think in future she will end up having THR. Maybe this thing is going to get aggravated because of the spine surgery.
Did you confirm her pain source by injection?
No, I didn't confirm because her disabling, that's what I said. This was like a simple primary hip spine syndrome where her symptoms were in the posterior part of the thigh, posterior part of the calf also, and her debilitating symptom was more of a back pain rather than a groin pain. So that is why I didn't do injection in this case. But and then the X-ray didn't suggest major OA. So that is why. If the X-ray would have had a very bad OA where the head has deformed or something, then I would have definitely done injection.
So what we understand is primarily the patient had a claudicating symptoms, and post-surgery the patient did do well.
Yes.
But if you see the X-ray, there's significant arthritis there. My question is that if this patient would have had a significant clinical hip pain as well, then would you have done the hip first or
The spine first and then the hip. Definitely, as the literature suggests, if you have to do a longer fusions in the spine, then do it first and then do hip.
Actually, on the contrary, I was reading some of the articles that you first.
So actually,
the
it depends on
back
who has
better.
published the papers.
Correct.
And actually, and also, yeah, Doctor, yeah.
No, so I was just going to say, I think as spine surgeons, we have the luxury of going whenever we want. It's really the hip surgeons that care if we go first or not, because if we feel that the spine is their pathology, we fix their spine, and the hip surgeons will have a stable spine or at least a fixed alignment to target, and they can take into consideration
Yep.
the type of liner they use, et cetera. Or if they do the hip replacement, it doesn't really affect our decision-making algorithm in a significant way when it comes to addressing the spine. So I think for us, this debate, I mean, it's an important debate to consider because obviously it's a patient counseling issue. So the patient needs to know whether or not they're going to need additional surgery, whether or not they'll get better. And certainly you don't want to do an unindicated procedure. But I think as spine surgeons, we have the luxury of treating the spine pretty much however we want to treat it. It's really the hip surgeons that have to worry.
Actually, in few spines, we all know that in Anki, we always did hip first and then the spine later. But then there also, in Anki, if you read recent literature, they are saying do first spine first and then do hip later. Because of the higher chances of anterior dislocation in these joints when they do hip first.
All right. My only concern here is, and if the house could also address it, is when we are doing long fusions, and in today's era where we are trying to correct the global spinal balance, after doing the hip surgery, there's a lot of correction that happens, auto correction. Fine. So do you feel that after doing the hip, you are going to
Okay,
change
that's
the amount of
that's a
correction?
misnomer. Doing a hip really doesn't correct the spinal parameters, spinopelvic parameters. Only thing which gets corrected is usually the scoliotic deformity, which gets corrected more. But then the pelvic tilt really doesn't get corrected because of doing THRs.
So I meant scoliotic deformity.
That
So like in this
anyhow, we are not worried about more of a scoliotic deformity. We want to what correct is a pelvic tilt, that which doesn't get corrected with the THR. Thank you.